والحمد لله رب العالمين. Hello to all my colleagues and all my fans and all my friends and students everywhere. النهارده انا هتكلم this topic is for healthcare professionals, for clinicians, because it is a clinical topic. And today I will speak in short about the important clinical syndromes related to pancreatic endocrine tumors. That is pancreatic endocrine tumor syndromes. وهي to start with تشمل مجموعة من it includes a group of syndromes related to tumors affecting the endocrine part of pancreas, because as we all know البنكرياس في جزء منه exocrine وفي جزء منه part of the pancreas is exocrine, responsible for digestion and absorption because it secretes enzymes, and the most common the lipase and amylase enzymes, which are responsible for or which play a role in digestion and absorption of nutrients of food in the gastrointestinal tract. And there is also an endocrine part of the pancreas, which includes, as we all know, alpha cells, or sometimes we call it the A cells, beta cells, or sometimes we call it the B cells, and delta cells, or sometimes we call it the D cells, and other smaller cells in these islets of Langerhans. This is what we call the islets of Langerhans, which constitute the endocrine part of the pancreas, and it includes, as I mentioned, alpha cells, beta cells, delta cells, and other smaller cell groups. The endocrine part of the pancreas might be affected by tumors. بالظبط زي exocrine pancreas. Exocrine pancreas can be affected by other tumors. Most common is adenocarcinoma of the pancreas, which is the commonest type of histologic type of pancreatic exocrine malignancy. برضو هنلاقي ان في on the other hand there is also tumors which affect the endocrine part of the pancreas. And the most common of these tumors are the insulinoma. Insulinoma, it is a pancreatic endocrine tumor, one of the neuroendocrine tumors of the pancreas. وانا سبق واتكلمت قبل كده على neuroendocrine tumors والبارانيوبلاستيك syndromes related to the neuroendocrine tumors في كذا محاضرة ليا من سنتين على 2 years ago in one of my lectures in the internet, in the Google and also in the YouTube. To remind you again, the insulinoma, it is one of the pancreatic endocrine tumors, and usually it is benign, but it may progress in its natural history, in its natural biologic history to become malignant, but in most of the cases it is benign. But the importance or the significance of the tumor is not in its benignancy or malignancy, it is in its functionability. That is, it is a functioning tumor. It secretes hormones. It is producing a hormonal syndrome. So it disturbs the body functionally by production and secretion of a particular or a specific hormone. In the insulinoma, it arises from the beta cells of islets of Langerhans, which secrete insulin. زي ما احنا عارفين الانسولين ده is a polypeptide hormone زي ما كلكم عارفين, as you all know فيها 51 amino acids, 2 polypeptide chains connected together by 2 bonds. It is 51 amino acid, وهو derived من حاجه اسمها البرو انسولين اللي هو عباره عن الانسولين مع سي بيبتايد تشين, والبرو انسولين 84 amino acids. Anyway, I'm revising for you the biochemistry of insulin. And many physicians forget this basic medicine when you ask them, especially with the business of life, clinical life. So this tumor is producing insulin, insulinoma, or overproducing insulin. This overproduction of insulin from this tumor, and this tumor presents with hypoglycemia, and this tumor is diagnosed clinically by a clinical triad called Whipple's clinical triad. And this Whipple's clinical triad is the clinical presentation, and it is the paraneoplastic syndrome related to insulinoma, producing excessive insulin. And as we all know, when there is overproduction of insulin, there is hypoglycemia. In contrary to when there is undersecretion of insulin or insulin deficiency, there is diabetes, characterized by hyperglycemia biochemically, as we all know. So there is hypoglycemia here in the insulinoma syndrome, So there is hypoglycemia, fasting hypoglycemia, not reactive, because as you all know, we divide hypoglycemia into fasting hypoglycemia and reactive hypoglycemia, and there are causes or etiology of fasting hypoglycemia and etiology of reactive hypoglycemia. Here we have fasting hypoglycemia, and we have fasting blood glucose less than 50 milligram per deciliter or 55 milligram per deciliter or 2.7 millimole per liter. And number 3, there is relief of hypoglycemia. There is symptoms of hypoglycemia. That is acute hypoglycemia due to sudden reduction of blood glucose, because this tumor produces recurrent fasting hypoglycemia and recurrent episodes of hypoglycemia. So the patient suddenly gets acute hypoglycemia with faintness, with instability, with tremors, with tachycardia, sudden sensation of hunger, and with tremors. And these manifestations are suggestive of are adrenergic features, suggestive of, due to release of catecholamines, of course, suggestive of the occurrence of acute hypoglycemia. Because as we all know, acute hypoglycemia produces adrenergic symptoms, that is sympathetic symptoms related to secretion of catecholamines, while chronic hypoglycemia, that is hypoglycemia developing gradually, not suddenly, developing gradually, will produce manifestations of what we call neuroglycopenia due to deprivation of nervous system from glucose. So here we have acute hypoglycemia with hypoglycemic symptoms. This is number 1 of the clinical triad, and we have when we measure the blood glucose, there is reduction of blood glucose below 50 milligram per deciliter or 3 millimole per liter, as I mentioned. And number 3, relief of hypoglycemia symptoms when we administer immediate cessation or immediate improvement of the hypoglycemia symptoms with intravenous administration of glucose, when we give the patient intravenous infusion of or infusion or bolus of dextrose 50 or D50 infusion. لما بندي مجرد ما بندي المريض على طول دextrose، وعلى وجه التحديد في الحالات ده هي بندي D50 مش D5 ومش D10 in water. So D50 in water glucose will improve the symptoms. فالترياد عبارة عن symptoms of hypoglycemia, acute hypoglycemia. لما نقيس نمرة 2، لما نقيس البلاد جلوكوز اللي هي أقل من 50 ملغرام بالمليجرام أو بالمليمول 2.7 millimole per liter. Number 3, the symptoms of hypoglycemia improve immediately, and the patient gets normal when we infuse him with D50. This is the features of insulinoma syndrome, and this is called the Whipple's triad. Now I will shift to the second tumor. مش هتكلم هنا in details على كل حاجة. Just I'm revising quickly the pancreatic endocrine syndromes related to pancreatic endocrine tumors. Number 2 syndrome and number 2 tumor is the glucagonoma. Glucagonoma syndrome is related to it is a paraneoplastic syndrome related to a pancreatic endocrine tumor called glucagonoma, which arises from the alpha cells of islets of Langerhans, or A cells of islets of Langerhans, with overproduction of glucagon hormone. That's why there is glucagonemia, that is increased level of glucagon in the blood due to overproduction and oversecretion of glucagon by this tumor. And the syndrome resulting from glucagonoma is the clinical triad consisting of glucagon secreting tumor, diabetes mellitus, and a rash called necrolytic migratory erythema, or NME. Here, this is very important. That's why I'm mentioning this, to revise to all of you the clinical features And it is important to remember the NME, the necrolytic migratory erythema, because this erythema is characteristic of glucagonoma, and it is a paraneoplastic feature of glucagonoma as a pancreatic tumor, and of the glucagonoma syndrome, which is a clinical triad of, as I mentioned, diabetes due to overproduction. عارفين glucagon is an insulin antagonist, and it causes hyperglycemia. عكس الانسولين بيعمل hypoglycemia. So here there is diabetes mellitus, and the diabetes with glucagonoma, by the way, it is moderate to severe type of diabetes. It is secondary diabetes. It's unlike the other types of primary diabetes which we see in the general population اللي احنا بنشوفها التايب 1 والتايب 2. ده نوع خاص اسمه secondary diabetes due to endocrine cause. And here the endocrine cause is the glucagonoma. So there is here diabetes which is moderate or severe in intensity or in severity. And there is a characteristic rash called necrolytic migratory erythema, and this rash is erythematous rash with blisters, that is erythematous blistering rash, which spreads over the skin of the body, usually on the face and around the mouth and on the limbs, especially the distal parts of the limbs of the patient, and also upper limbs and lower limbs, and they may be seen on the trunk, especially on the lower abdomen and on the back of the patient, and they may be even generalized in severe cases. The rash is called necrolytic migratory erythema because there is erythema and necrolysis of the skin, and this erythema is migratory because it spreads on the skin and becomes diffuse. That's why here examination of the skin is very mandatory and very important in these patients with suspicious glucagonoma syndrome. So there is necrolytic migratory erythema, there is diabetes mellitus, and a tumor in the pancreas which is detected by ultrasound, confirmed by CT's abdomen, or MRI of the abdomen focusing on the pancreas, and other radiological investigation to diagnose the presence of the tumor, and then take biopsy and confirm the histology or the histopathology of the tumor, and other, of course, pathologic examinations, immunohistopathology and cytochemistry and these things. So this is very important to remember the necrolytic migratory erythema, or the NME, diabetes, and glucagonoma. Characteristic of the glucagonoma syndrome. Sometimes we say that there is 4 Ds of glucagonoma also, because there is diabetes, there is dermatitis with this classic rash, the NME. There is also depression in these patients, and there is dizziness. So there is, and deep vein thrombosis sometimes also. So the deep venous thrombosis, the depression, and the dizziness and the diabetes, these 4 are starting with D. That's why we call the 4 Ds of, or the 4D of the glucagonoma syndrome. Again, I will repeat again: diabetes, dizziness, depression, and deep venous thrombosis due to hypercoagulability, which is one of the paraneoplastic features of the glucagonoma syndrome. These are the 4 Ds of the glucagonoma syndrome. So don't forget the necrolytic migratory erythema as a part of the glucagonoma syndrome. And this has to be differentiated from other types of erythema, especially the erythema gyrata repens and the erythema multiforme and these things. You have to differentiate between these types, because here the rash or the dermatitis specific rash is associated with erythema and blistering, as I mentioned, and necrolysis of the skin. That's why we call it necrolytic migratory erythema, or we abbreviate it as NME. Let us now shift to the third endocrine tumor, which is the somatostatinoma. And somatostatinoma, it is another pancreatic endocrine tumor arising from the delta cells, or what we call sometimes we call it the D cells of the islets of Langerhans. So I mentioned that the insulinoma arises from the beta cells of islets of Langerhans. So the glucagonoma arises from alpha cells of islets of Langerhans, or the A cells. And the somatostatinoma arises from the D cells, or the delta cells of the islets of Langerhans, which is the endocrine part of the pancreas. And this hormone, the somatostatin, it is a very important hormone, which is, if secreted in high amount or in large amounts, it inhibits other pancreatic hormones, and it inhibits the gastrointestinal hormones. The hormones secreted by the stomach, like the gastrin, and also the cholecystokinin and the pancreozymin and the secretin, that is, it interferes with other hormones secreted by the gastrointestinal tract or the cells of the gastrointestinal tract, and which affect the gastrointestinal secretion and the gastrointestinal motility. That's why you find that patients with the somatostatinoma syndrome is characterized by a triad of also diabetes. So there is here also diabetes, like in patients with glucagonoma, there was also diabetes. But the diabetes here in somatostatinoma is mild diabetes. It's milder than the diabetes of the glucagonoma syndrome. على عكس انا قلت البيشنتس ويز انسولينوما بيبقى عنده هايبوغلايسيميا اللي هي الويبلز تراياد اللي انا ذكرتها في الانسولينوما. لكن اذا الانسولينوما فيها هايبوغلايسيميا، الجلوكاجونوما والسوماتوستاتينوما فيها هايبرغلايسيميا، that is diabetes mellitus. The diabetes of glucagonoma is mild to severe. The diabetes of somatostatinoma is mild diabetes, because the effect of somatostatin on the blood glucose carbohydrate metabolism is milder than, or is less severe than, its effect on the effect of glucagon on glucose metabolism. That's why the hyperglycemia in somatostatinoma is mild hyperglycemia or mild diabetes mellitus, in contrast to diabetes of glucagonoma, which is moderate to severe. So here there is also in somatostatin mild diabetes, there is diarrhea due to malabsorption, or sometimes we call it steatorrhea. There is a steatorrhea here because it interferes with the overproduction of somatostatin, interferes with the process of digestion and absorption of nutrients. So there is malabsorption with steatorrhea, that is fatty diarrhea due to interruption of carbohydrate and fat metabolism due to the overproduction of somatostatin. So there is here steatorrhea, which is a type of fatty diarrhea, in addition to diabetes, and there is what we call also cholelithiasis, gallstones. So here gallstones is characteristic of somatostatinoma. So there is cholelithiasis, that is gallstone formation. There is diabetes. There is, as I mentioned, also a chlorhydria. So a chlorhydria, which is reduction in the stomach acidity or absence of stomach acidity. So there is hypochlorhydria or achlorhydria due to inhibition of gastrin, which stimulates the production of HCl by the stomach due to overproduction of somatostatin. So the clinical triad here of somatostatinoma is diabetes, is diarrhea, cholelithiasis, in addition to the chlorhydria. This is the triad, and we can say tetrad of somatostatinoma. The diabetes, mild diabetes, steatorrhea or diarrhea. Number 3, cholelithiasis, that is gallstones, and number 4, achlorhydria. This is the clinical syndrome of somatostatinoma due to overproduction of somatostatin by a somatostatinoma tumor of the pancreas. Now I will shift to the 4th type of pancreatic endocrine tumor, which is VPOMA syndrome. And the VPOMA syndrome, or VIP, OMA means tumor, and VIP is another hormone produced by also the non-beta cells, or the non-beta part of the islets of Langerhans of the pancreas. And this vasoactive intestinal polypeptide secreting cells, when they get neoplastic or they behave in a neoplastic manner or biologically form a tumor, we call it the VPOMA syndrome or the VPOMA tumor. And it causes a paraneoplastic syndrome, which is formed of the following triad, or you can say tetrad. That's why we call it WADHA syndrome. There is watery diarrhea. Number 1, it is a triad of watery diarrhea, hypokalemia, due to loss of potassium from the gut due to the diarrhea. So the electrolyte على وجه التحديد البوتاسيوم is lost with the watery diarrhea. So there is watery diarrhea, there is hypokalemia and achlorhydria. يبقى هو بيعمل achlorhydria مشترك زي السوماتوستاتينوما, common with the somatostatinoma syndrome. But here there is, again, I will repeat the clinical triad. There is watery diarrhea, number one. It is a watery diarrhea, not steatorrhea. In somatostatinoma, it is a fatty diarrhea, different from the watery, because here the mechanisms of the diarrhea, or what we call the pathologic mechanisms of the diarrhea, is different. So the mechanism of diarrhea in vipoma is different from the mechanism of diarrhea, or the pathobiology of diarrhea, or the etiopathogenesis of diarrhea in somatostatinoma. In vipoma, it is watery diarrhea. In somatostatinoma, it is steatorrhea. Again, in vipoma syndrome, there is watery diarrhea. There is hypokalemia due to gastrointestinal potassium loss. So there is hypokalemia, and there is achlorhydria. Same like in somatostatinoma. هنا الحاجة المشتركة, the one common between both syndromes, somatostatinoma and vipoma, is the presence of hypochlorhydria or achlorhydria. That's why we call it the Wadha syndrome. That Wadha means watery diarrhea. H is hypokalemia, A is the achlorhydria, Wadha syndrome, or WDHA. WDHA syndrome is watery diarrhea, hypokalemia, achlorhydria of vipoma syndrome, which is due to vipoma that is pancreatic endocrine tumor secreting vasoactive intestinal polypeptide. This is, in short, the difference between the insulinoma and the glucagonoma and the somatostatinoma and vipoma, and the related clinical syndromes and the clinical triads or tetrads characteristic of these syndromes, as I have already mentioned. My regards to all of you, and I wish to all of you a peaceful day, and stay peaceful and safe, please.